So just to welcome everybody. Thanks for joining the meeting today. It's about an update on the new dermatology training curriculum and then maybe and later on the portfolio. And I'm very, very pleased to introduce Matthew Scora, who is the new national lead for the dermatology curriculum. And I'm very grateful, in fact, that is joining us to talk us through. So with this, I hand you over the baton to get started. And if you want to say a few more words about yourself, you're more than welcome, Matthew. Thanks.
Thanks, Effie. So I'm Matt Score. I'm TPD in the East Midlands. I cover the south part of the region, and I have a job share with Kidwan Shum in the north. And yes, I've taken over as the SAC lead for curriculum and assessment, mostly on the basis that all the work's just been done, and hopefully I won't have to do too much curriculum update. But hopefully I can be helpful by sharing this information with you. So I'm going to start by talking through the curriculum today. Can I just confirm if you can see my slides?
Yes, we can.
And
yeah.
is it moving?
Yes.
Yeah.
Great. Okay. Perfect. So what I'm going to talk about in the first section is what is the new curriculum? Why did it change? What is it that's changed from the previous curriculum? And then actually we'll go through in a bit more detail about what's in there that you need to know in terms of the content of learning, the teaching and learning methods. So how do we learn what needs to be learnt? And the program of assessment as well. And one of the questions might be, well, what's happened to the syllabus, which has been taken out of the curriculum? So I'll be able to answer that question. Can I just make sure everyone's muted? So I'm getting a lot of feedback. That's better. Okay. So the curriculum was updated in August 2021. That's when it came into action. So nearly 2 years ago now. And the idea of a curriculum is a description of a course or a training program. So it should cover really sort of every aspect of what a training program intends to achieve and what it involves. So the purpose of the Dermatology 2021 training curriculum is to produce general dermatologists. So that means that when people complete the training program and CCT, they should be able to walk into any dermatology department in the UK, whether that's a tertiary specialist centre or a district general hospital, with the capabilities to safely recognise, diagnose and manage the full range of common skin conditions, including hair, nail and mucosal conditions. So what the curriculum does is it defines that content of learning. What is it that we need to learn to perform that role? The process of training, how do we get there? And the program of assessment to make sure that people are achieving the learning before we sign them off for their CCT. The curriculum in full is available from the JRCPTB website if you want to access it. And there's a number of other supporting documents alongside it as well. So particularly there's one called the Rough Guide to the Dermatology 2021 curriculum. And if you've not read that already, then I would recommend reading that as a minimum. It's a very helpful, practical guide to the things you really need to know. The ARCP decision aid is also there, and you're probably used to consulting that to work out what it is that registrars need to get through their ARCP. And there's also the separate dermatology syllabus guidance, and as I said, that now sits outside of the curriculum, and we'll come to that later in the talk. Okay, why did the dermatology curriculum change in 2021? Well, there's a couple of aspects to that. One is the wider context. So across all of medicine in the UK, the GMC wanted to introduce new generic professional capabilities across every single specialty, so the 66 different specialties that they accredit. And the idea of this was to address areas where complaints about doctors come from, and to address areas highlighted in safety inquiries. So obviously from the GMC point of view, that's what they're interested in, demonstrating to the public that doctors are sort of appropriately accredited and trained. And also there was an intention to support flexible training for doctors, which means that in theory it should be easier to transfer between specialty curricula if people decide to change their career path, and it'll be easier to see where they may have already achieved experience in some areas that are generic across medical roles. In dermatology, obviously, we know dermatology is a rapidly changing specialty, particularly in the last 3 years. That can be both professional advances like new therapeutics, biologics, the ever-growing burden of skin cancer as part of the specialty, and changing models of care. So teledermatology was on the rise before COVID, but has obviously exploded in the last 3 years as part of our day-to-day practice. And of course, there are changing population needs, and people's medical needs become more complex through aging, comorbidity, and polypharmacy. And the background to all of that in dermatology is our well-known workforce challenges as well. So there was a need to look at the previous curriculum, which had been in force for around a decade. What are the big changes from 2010 to 2021? Well, the core thing that has changed is the introduction of capabilities in practice, or SIPs. So just to get your head around the jargon here, previously the 2010 curriculum was based around a competency approach. So you had to sign off many individual competencies, which all needed separate evidence linked and needed to be approved en masse at the end of training. And this was sometimes criticised as an over-granular tick box exercise. So the SIPs, the capabilities in practice, are based on this concept, which has become more popular worldwide in medical education, called entrustable professional activities. So the idea is that each doctor, their job is made up of a number of tasks, essentially, and it's a relatively small number of tasks if you look at it at a high level. And the best people to assess whether a trainee is up to doing the job of being a consultant dermatologist are consultant dermatologists, who are their supervisors. And these entrustable professional activities, say for example, the ability to run a skin cancer clinic, is a kind of intuitive thing to someone who's already doing it. So is that person up to the job of running a skin cancer clinic, and what degree of supervision do they require in order to do so? So they reflect relevant real-world performance rather than being lots and lots of little tasks that you may or may not do as part of your consultant career. And they utilise that expert assessment of supervisors like you and I. One of the other changes in the new curriculum was a new entry route to dermatology specialist training. The curriculum does clearly emphasise still that dermatologists require a sufficient medical or physicianly background, reflecting that increasing complexity with comorbidity and polypharmacy. So we do need to have a good founding in medicine, and the MRCP therefore remains the normal requirement for entry into training, which the majority of people will achieve first. However, for some time, there has been the paediatric route, where you can do the MRC-PCH exam, 2 years of paediatrics, and an additional year of adult general medicine. And mirroring that, there is now a surgical route to training. So if people have done 2 years of core surgical training and done the MRCS exam, and then also got an additional year of adult general medicine, then they will be eligible to apply to dermatology training. And some of this was slightly political, I think, coming out of the changes to physicianly training, where more specialties were pushed towards dual accreditation. So, for example, rheumatologists in the last few years have been able to either specialise just in rheumatology or to dual accredit in rheumatology and general internal medicine. but with a push towards trying to get more people onto that GIM training and GIM rotas, a large number of medical specialties now have to dual accredit, but dermatology fortunately isn't one of them, and the BAD obviously pushed very hard for this to reflect the fact that we need a good foundation in medicine, but we also need the specialist training in order to manage adults, children, surgical problems. And I think as part of a concession towards that, essentially the surgical was opened up in order to keep dermatology out of that change. I'm not sure I've seen anyone come through it yet. Obviously, it started 2 years ago, but it's one to keep an eye out, I think, for the future. The duration of training hasn't changed. Essentially, dermatology training is still anticipated to be 4 years of whole-time equivalent clinical training. The curriculum does outline the fact that trainees can complete training sooner, so long as they're demonstrating exceptionally rapid development and acquisition of capabilities. And this is becoming more of a frequent thing in people having had experience at the equivalent of registrar level, but the training that's delivered in, for example, clinical fellow posts is quite variable, and the evidence that people gain during those posts is also very variable as well. So this needs to be carefully considered once people come into a training program. There's also an acknowledgement that some trainees might develop more slowly, so we don't all have a kind of internal clock ticking down from 4 years, and as soon as that alarm clock goes off, we're suddenly capable of being a consultant dermatologist. So we need to have some flexibility in training time, but it's always done through an ARCP panel, and that's the only place that a decision can be made in order to change a CCT date. In practice, the SAC recommends that a maximum of 1 year of clinical training time would be taken off to reflect well-evidenced, directly relevant clinical experience. In theory, it is possible to have a little bit more than that, but 1 year is the usual maximum. The content of learning. So what actually is in the new curriculum, and we'll go through the SIPs. So we'll start with generic SIPs. It's important to be aware of what these are, because as educational supervisors, before each ARCP, you're going to rate your trainees as to where they are performing in line with all of the capabilities in practice. So generic SIPs are the things that all doctors should be able to do at senior level. The first is to successfully function within NHS organisational and management systems. So these are skills around leadership and management. The second is ethical and legal issues related to clinical practice. The third is communication, shared decision making, situational awareness, professional behaviour and judgment. The fourth is a focus on patient safety and the ability to deliver effective quality improvement. So these are sort of rolled together. The fifth is around research and data management. So the data management aspect can overlap to a degree with the quality improvement and audit aspects as well. And the final generic capability is to be able to act as a clinical teacher and a clinical supervisor. If you were to go into the curriculum and look at each one of these SIPs, there's quite a lot of detail in terms of what we are expecting of trainees by the end of training, and each one of these SIPs has descriptors which will outline if you're thinking about someone at the end of their training, where should they be? So for example, you may not be able to read the text fully, but this is generic SIP 5, which is carrying out research and managing data appropriately. And some of the descriptors might read, for example, that demonstrates the ability to carry out critical appraisal of the literature, demonstrates the role of evidence in clinical practice, and demonstrates shared decision making with patients. So if you are trying to work out what does a registrar actually need to achieve in terms of research to pass a dermatology training program, then you would essentially look at the descriptors and say, have they met this yet? Yes or no? And each one of the SIPs also has some suggestions of where the evidence for that may be found. So that might be in work-based place assessments, it might be in MSFs, it might be in other things like having a GCP certificate in the research domain. So as an educational supervisor, we're going to talk about the portfolio and educational supervisor report in the second half, but the way you would rate generic SIPs is quite straightforward. It's either below expectations, meeting expectations, or above expectations. So you do have to have that slight mental adjustment of, okay, this person's coming to the end of their first year of training, so I'm not expecting them to have met everything, but are they on track to do so? The other thing I would say about those ratings, the below meets and above expectations, is that we're all consultant dermatologists, so we're all really nice people and we like to be kind and very warm to our trainees, but not everyone is above expectations by the law of averages. So most people are going to be meeting expectations, and I would encourage you to try and be judicious about that, because it is something that will be used if a trainee comes to us on an ARCP panel and says, I want to move my CCT date forward because I'm doing really, really well and all of my ratings are above expectations. We want to be able to look at that critically and say, yes, we agree from the evidence, or no, actually, we think you need a little bit longer. And that job's a lot easier if that full range of ratings is used. Okay, specialty SIPs. So what does a consultant dermatologist do? So there are 7 of these. Number 1 is outpatient dermatology or general dermatology. Number 2 is acute and emergency dermatology. Number 3 is liaison and community dermatology. So this involves, for example, liaising with GPs, maybe teledermatology will fall within that quite a lot of the time as well. Skin tumours and skin cancer. So this is mostly around skin cancer clinics. And then procedural dermatology is a separate category. So that includes surgical and non-surgical procedures. Pediatric dermatology is a core part of the specialty and remains so it's not considered one of the subspecialty areas. So all trainee dermatologists will need to have good skills in pediatric dermatology. And finally, the 7th category is the specialist areas, and we're not expecting trainees to be a subspecialist in any or all of these areas by the end of 4 years of training. So I would think of this as specialist dermatology for the general dermatologist. So when you encounter, for example, a patient with hair loss in a general dermatology clinic, are you able to make a sensible decision around initial management and potentially onward referral for subspecialty opinion where appropriate? And there's 4 domains within this, which are cutaneous allergy, photobiology and phototherapy, and then genital mucosal disease, and finally hair and nail disease, which was pretty much absent in the previous curriculum. And again, if you wanted to go into the detail and look at the curriculum and think, okay, what does someone need to achieve in outpatient general dermatology, you can look at the descriptors, and there are some which are quite sort of broad within this. So, for example, demonstrating effective consultation skills, and there are some which are much more specific. So, demonstrates the appropriate use of assessment tools with regards to disease severity and impact on quality of life. And a bit further down, there's one around demonstrating safe and effective prescription management and monitoring of advanced systemic therapeutics such as immunomodulators, immunosuppressants, biologics, antimalarials and retinoids. So these are the kind of things that trainees should be finding evidence for, putting it in their portfolio and linking to this capability. So the way that you rate the specialty SIPs is a little bit different to the previous ones. And for these ones, what you're looking at is to what degree do you trust this person to perform this task? So, for example, to run a general dermatology outpatient clinic, And there are 4 levels, although I have to say that level 1 you're probably not really going to be using, because level 1 means entrusted to observe only and not to provide clinical care. So apart from perhaps a short induction period, the majority of people are really going to be getting stuck in at level 2, which means entrusted to act with direct supervision. So there's a clinical supervisor present or immediately available. So most people in ST3 are going to be starting at that level. And then the idea is that you'll show progression through to level 3, which means entrusted to act with indirect supervision. So the supervising doctor doesn't necessarily have to be physically present, but should be available at least by telephone. And then finally, to complete training, everything should be level 4, which means entrusted to act unsupervised. And each one of those 7 areas will progress at slightly different rates. So clearly, most trainees are going to get more experience in skin cancer and general dermatology early in training, and they may develop other areas such as pediatrics and the specialty aspects a bit later in training. So there is a grid within the curriculum, and I think it's in the rough guide as well, of where trainees should be at each progression point. So what should they have achieved by the end of ST3? What should they have achieved by the end of ST4, etc. Within the curriculum, there is also a list of presentations and conditions, and this just gives you a rough idea of the areas in which trainees should be getting experience, and most of these will be included within those 7 SIPs, but there are a few which lie maybe outside of it, just to make sure that they're not missed. So for example, skin disease in pregnancy is there, and also psychocutaneous medicine, which is obviously very important. And this is just to show that although it might not necessarily have its own specialty capability, it's still a core thing that dermatology trainees will need experience of. And these kind of categories you might take into account if you are looking at a penultimate year review. So someone who's got a year left in their training, have they had adequate experience in all of these areas? And for example, if they've not had any psychocutaneous medicine training, do they need to go to some clinics or run a course for that? The next part of the curriculum is surgical procedures, and there are I think 11 surgical procedures which are listed, and this is a little bit different to the old curriculum because the trainees do need to get all of these signed off with DOPS, and the majority of them they'll need to be independent by the end of training. And again, there's a grid, a matrix showing that they should achieve some of these early. So for example, punch biopsies and incisional biopsies, they should be independent in that by the end of the first year of training. And you can see there's CNC cryotherapy is a surgical DOPS. I often see that accidentally done as a non-surgical DOPS. Dog ear repair, excision of lesions on trunk and limbs and head and neck, shave excisions, and then genital and mucosal biopsies. So by the end of training, they should be able to do all of that independently. And there's one which is the odd one out, which is a small flap repair. And by the end of training, trainees should be able to perform that under direct supervision. So they should have done it at least once. And the idea is not that everyone will be going on to be doing advanced repairs during their surgery, but that a core skill of today's dermatologists is to understand the indications and to get an idea of how a flap is chosen and performed by someone who probably will undergo some further subspecialty training. And this has been a little bit of a controversial thing nationally. I think some regions find it actually quite difficult to achieve this, whereas other regions don't seem to have a problem. But it's something that came up in the GMC review of the new curriculum once it was implemented. So if you do have any feedback about curriculum areas being difficult to achieve, then please let me know, and we'll be able to keep an eye on it and inform any future changes. The non-surgical procedures they've come up with these 5 compulsory non-surgical procedures again, which need to be assessed with DOPS and rated, and that includes dermoscopy. And clearly, you don't just observe dermoscopy once and say people are competent to do dermoscopy on every single different type of lesion in every different context. So that's quite a good one to be repeating multiple times in different contexts. There's DLQI and other assessments, so PASI, EASY, etc. Triamcinolone injection, taking skin scrapings and nail clippings for mycology, which is a slight change because they used to suggest actually doing direct microscopy, but that's becoming less and less common to have access to microscopes and potassium hydroxide preparations and so on. So this reflects more the real world of what every UK dermatologist should be able to do. And finally, Wood's light examination, which perhaps is something we do a bit less commonly, but that's one that I think a few people have noted, and you've got to maybe dig out your departmental Wood's lamp and make sure you've allocated which dark cupboard you're going to perform those DOPs in. The next section is the teaching and learning methods. So those are the learning outcomes. That's what we want trainees to have achieved at the end of their training, and how do we actually get them there? Now, the curriculum doesn't tend to be too specific about this because clearly training programs are going to differ quite a lot from region to region, but there are some helpful things in here. And one I think which is quite useful is an expectation around outpatient clinics, and emphasizing really the importance of work-based experiential learning for dermatology. And we all know that dermatology learning isn't just about going on courses and reading Rook from front to back. It is about seeing lots of patients in clinic, getting used to managing uncertainty, and seeing what real life practice is like. So the indicative patient numbers are given in the curriculum, and this matches up essentially with the BAD consultant job planning guide, which suggests that a consultant dermatologist should be able to see between 13 and 16 patients in a general dermatology clinic. Now, I think arguably things have shifted a bit, and with the increasing use of teledermatology upfront and triage, our patients may be getting more complex. But I think this gives a rough guide really that we should be aiming for ST6s by the end of training to be seeing 13 patients. And what I try and do locally is to gradually increase the numbers as they go through the training years. The time that you need within specialist clinics isn't specified in the curriculum, but the rough guide has a few helpful recommendations. So for those of you who either run specialist clinics, or if you are a program director, then you'd be thinking about how long do I need to get trainees into these clinics for, what's usual around the country. And some of these are probably relatively straightforward to achieve. So weekly skin cancer clinics for at least 18 months of training, which is less than half of training. I think generally trainees are going to be experiencing quite a lot more skin cancer than that, but that should be considered a minimum. Contact dermatitis clinics, so patch testing rotations, they recommend a minimum of about 4 months, and that's a helpful figure to have in your head. And then pediatric clinics, 6 months with 1 or 2 clinics per week. And again, I think probably most regions have a bit more than that. And I think possibly these figures are somewhat helpful for trainees, but I think they're also very helpful for CSER. So if you're looking at people who are coming through the CSER route, what will be the equivalents to specialist training? Because I think the specialist clinics are often an area that it is more difficult to judge whether people have had adequate experience. The other thing that the rough guide says is about other clinics that are to be attended if they're available, but it does acknowledge that these kind of patients don't have to be seen in a specialist clinic to achieve adequate exposure. And perhaps this is a little bit of a shift, but it's acknowledging that patients can present to general dermatology clinics, and obviously that learning can be supplemented with courses and e-learning, and that's around hair and nail disease, oral, vulval and male genital disease, and photobiology. So you're not going to fail a training program if you've not been to a specialist nail clinic, for example, but you clearly do need to demonstrate somehow that you've acquired the capabilities to manage those patients within a general dermatology clinic in line with the specialty SIP. So there's a bit of flexibility there, but you definitely still need to have experience. So there's a question that's just come up. I think we're going to have a question and answer session in a short period, so we'll save that for a minute. Acute dermatology trainees must have a regular commitment to acute dermatology related take for most of the training period, and that's necessary to make sure they can manage acute presentations, but also how to triage and prioritize and recognize urgency of care. And what the curriculum states is that it does not have to be out of hours, and that's a concession to the reality of the fact that a lot of dermatology services don't have out of hours because the trusts won't commission it or the commissioners won't pay for it. So although that's still preferred, because that is potentially the best way to learn really how to properly prioritize and recognize urgency, it doesn't necessarily have to be out of hours experience. The curriculum also includes a few areas where trainees should get some experience sort of outside of their core clinical activities, so phototherapy and photodynamic therapy. It encourages exposure to dermatopathology, which again is a little bit patchy in terms of exposure, so it's not available in every hospital, but I know in both the West Midlands and the East Midlands we're fortunate to have rotations with really excellent specialist dermatopathologists, but the curriculum does encourage training programs to give trainees the opportunity to evaluate histology and discuss cases with pathologists. And teledermatology is a new aspect which is included in the curriculum in quite a small way, but it's there, and it's important that we give trainees exposure to it, and they must have sufficient exposure from primary and secondary care to be independent in teledermatology by the end of training. And it's important to clarify that there aren't any compulsory courses in dermatology training. Again, you can't pass or fail someone based on the fact that they have or haven't been on a certain course, but the curriculum does say that the BAD badged courses and also the e-learning for health dermatology, the online e-learning modules are recommended, and they're usually very closely mapped to the dermatology curriculum and training needs of our registrars. Assessments. So the SCE remains a passing requirement for CCT. Just bear in mind it is only once a year. It's usually in September or October, which is relatively early in the training year for people who are starting their training in August. And it's 200 single best answer questions. So for those of you who haven't sat the SCE, it's a clinical STEM, sometimes with an image, and then you've got 5 answers, and they may not be necessarily correct or incorrect, but it's the most correct answer that's considered right. Now, there are practice questions available on the MRCP website if trainees want to get an idea of whether they're ready to sit the exam, although the talk recently has been that perhaps those questions are a little bit easier than the actual exam. So I think that's just worth bearing in mind. It may just be that those questions have been on the website for so long that they've just become sort of subsumed into everyone's memory. I think with the SCE, it's compulsory to have at least sat it in ST5, and obviously you must have passed it by the end of ST6. But in the last couple of years, there has been a little bit of a drop off in pass rate. So previously, the pass rate for UK trainees with the SCE was very high, sort of heading towards 90%. But in the last couple of years, it's dropped quite a lot, and it's below 60%. And the reasons for that are actually a bit unclear. The exam is tracked, so they use certain anchor questions each year, so they can judge each cohort as to whether what the pass rate is and whether the exam truly is more difficult or not. And the exam doesn't appear to have become more difficult, but the pass rate has gone down. So this may reflect reduced exposure to courses and other aspects during COVID, potentially. But the fact is we don't know, and I think it's probably wise to try and encourage trainees to look into the SCE early, because if you're sitting at an ST5 and not passing on the first attempt, then that means you've got a very high stakes pass-fail exam in ST6, and because it's only sat once a year, that means there are a number of trainees nationally now who are having to extend their training in order to resit the SCE, and that's not really been a problem before. Work-based placed assessments are pretty much the same. 8 case-based discussions, so long case discussions per training year. A little tip that I think is quite helpful: I have an hour in my job plan each week where I have an open calendar, and I invite trainees to book directly into that to do CBDs, because otherwise they'll often complain that it's difficult to pin people down and do discussions. So I think that's quite a nice way of doing it, and it gives us a little bit of time and flexibility to go through those properly. The mini KEXs, there's 4 per training year, and these are the directly observed clinical encounters. So this should be done in vivo at the time a trainee is seeing a patient, and it can be done on the whole consultation or just one aspect. So you may do it on just history, just examination, or another aspect like, for example, giving informed consent for a surgical procedure, I think is a nice mini KEX to do. The DOPS are the directly observed procedures, and they're surgical, of which 4 are needed per year, and 2 non-surgical. And this is where trainees often will get more than the minimum required number. I think that's encouraged throughout the work-based placed assessments, but DOPS in particular, because you're having to sign off all of those surgical competencies now. Probably trainees are going to be aiming to do more of those. Multi-source feedback, another change that now has to be done every year, whereas it previously just used to be twice during training. But that's because multi-source feedback is often quite useful, particularly for underperforming trainees where there might be some issues, and often the MSF is really the first place that those issues start to come up, and can be spotted by supervisors and ARCP panels. And the patient survey remains 1 per training year. And almost universally, this is quite positive, but I think it's quite a nice thing for trainees to see that patient feedback, which we often don't have time to sort of step back and look at and see how much patients appreciate our care when we're working our way through very busy clinics. Audit in QI, now they should be doing a QI project assessment tool. Previously, people might have done things like audit assessments, but the idea is that audit should have a QI methodology or a QI focus, and they need 1 of those per year, and then a teaching observation each year, which is unchanged. Okay, the portfolio we're going to come on to, and then the syllabus. So as I said, the dermatology syllabus guidance is now a separate thing from the curriculum. So the curriculum itself is deliberately high level in terms of the learning outcomes. So it doesn't go into granular detail of every single bit of dermatology, every single condition that we expect a dermatologist to know about. So one of the advantages of taking this out of the curriculum is that it can be updated frequently. So actually updating a training curriculum is a huge process. It's essentially done through the GMC. It is really a decade-long process, so you can't just make agile changes. So for example, in 2020, when skin of colour was identified as an aspect of training that may be under-delivered, you can't just change the curriculum very easily to incorporate that, but you can change the dermatology syllabus and say, okay, what are we going to put in there to say that trainees need to know about skin of colour? So it's a living document. It can be updated in line with new developments, and it has a lot more detailed descriptors around different clinical presentations and expected knowledge and skills, but not completely exhaustive. And trainees don't need to get evidence for every single aspect of it signed off in their portfolio. The other thing trainees should know is that this is aligned with the SCE, so this is essentially the syllabus for the SCE as well. So anything that's in here can come up in the exam. Okay, so that's the end of the curriculum part. So I'm happy to take any questions now.
Thank you, Matthew. Thanks very much for this clear and detailed presentation. It's up to you if you want to take questions now. I'm happy. I mean, there is a question already in the chat box. 13 to 16 patients for an ST6 post ANR selection. Is this feasible?
Yeah, I think as I briefly mentioned, it's challenging. I think a lot of consultants would find that challenging in the current practice that we're doing, because all of the easy stuff is potentially being cherry picked out, whether that's through advice and guidance or whether that's potentially through community dermatology clinics as well. So I take that with a pinch of salt, but that's what the BAD consultant job planning guide says, and that's why it says that in the curriculum. And obviously the curriculum update was well underway before COVID happened. So I think, we recognise that the world has changed a little bit, but I think 12, 13 patients is a good aim to have, and actually time management skills, being able to manage a busy clinic, is a hugely important part of what a consultant should be able to do.
I see Shireen Velangi, who asked the first question, is typing something, but obviously we have to wait.
Yeah, no, it's okay. I just think it's unrealistic, because if we've got that in their curriculum, then you're when you're doing their supervision, you're asking them to speed up to something that is unreasonable, because the complexity of the patients that we're seeing, that they're seeing with us, is too high. So they can only ever see potentially 6 patients, 7 patients in a clinic as trainees. So it is difficult to get them to go to that level then, if that's the level that's written down, because there aren't those patients in the clinic.
I think that's a good point, and it depends a little bit on what your patient selection is, whether it's a specialty clinic. The thing you have to bear in mind is that they could walk into a clinic. The idea is that they can get a job anywhere in the UK, and they may be asked by their managers to say, okay, you've got a 4-hour session, you're seeing 13 patients, because that's what's the BAD job planning guide. And you can negotiate that as a consultant, but our trainees do see 12 or 13 patients by the end of ST6 in our clinics. So I think it is achievable, but it does depend on your patient mix and what's being cherry picked out.
Yeah. Fine. I mean, I think I had a couple of questions, to be honest. One of them was, and I'm grateful that you mentioned what the above expectation when you grade the SPRs, because it's not very clear what above expectation really is sometimes. And the other I've come across is that CNSs obviously sometimes rate our SPRs when they have the procedures done or when they break bad news. And I just wonder, when they say they meet expectations or they're above or below expectation, how are we to take this? I mean, if they are from a different profession.
Yeah, so the most important rating is that of the educational supervisor. So with the ARCP, when they consider the evidence, that's the first place that they'll go, is the ES report. So your job as an ES is to look over the other evidence around assessments that have been done by a variety of different people of different grades potentially, and come up with your overall impression of where that trainee is. So for example, a trainee might be related below expectations by a certain rater, by a certain person who they might have formed a certain opinion of them, but then everyone else says they're above or below, above or meeting expectations. So that doesn't mean they're going to fail their ARCP, but it means as an educational supervisor, you're going to look a bit more closely at that, say, okay, well, why has this person been related below expectations? Does that triangulate with your other evidence? And you're probably going to discuss that with the trainee as well at your meeting and say, as difficult as that is, why do you think that rating was given? And then the outcome is going to be your rating. That's really what the ARCP panel are going to look at. Oh, you're on mute, Teffy.
Thank you. The final one is, I think, the MCR, you know, the 4-consultant MCR report that every year the trainees, certainly for the sections pediatric dermatology and the specialties, photobiology and so on, very often 2 or 3 out of the consultants can't really rate it. What does this mean? I mean, how are we to use this then?
I think that is quite challenging. You're right to point that out. In the MCR, the ratings are also they're not quite matching up with that. On the MCR, it still says below meeting or above expectations, even for the specialty SIPs, which I think needs to change. And on the e-portfolio, I think obviously if you're asked to rate someone on their performance in paediatric dermatology and you've never seen them interact with a child, you know, you can't comment on it. And it's up to trainees to, you know, to seek appropriate MCRs to cover all of the aspects of training that they've experienced. And if they haven't experienced it so far, then fine. But one thing I would encourage is for trainees not to leave all their MCRs until just before ARCP for that reason. So, for example, certainly if you rotate partway through a year and you've just done a specialty rotation that involves, for example, a paediatric clinic, get an MCR because it will be fresh in the mind of your supervisor, your paediatric dermatology supervisor, and it's a very crucial part of evidence when it comes to the ES rating that at the end of the training year before ARCP.
Thank you. Are there any other questions? Okay, so then we close this and we move on to the portfolio review. Thank you.
Okay, thank you. So the next bit, I haven't got a presentation. I thought I'd just go through live and try and demonstrate how I would navigate around a portfolio if I was doing an ES report. So hopefully that will be instructive in some way. Okay, so can you see that? Can you see the NHSE portfolios?
Yes.
Yeah. So I've got a trainee who's very kindly given me written consent that I can go through his portfolio live because he's just coming to the end of his training. He's passed his final ARCP. And he's agreed for me to share that with you because I think this is the easiest way to explain it rather than to go through slides or still images. Now, I think most of you will probably be familiar with the NHSE portfolio, but this is just how I would go through it. And there may be 1 or 2 things which you might not be aware of. So you will have multiple roles often on the portfolio here. So this is me, and you can see I've got quite a large number of different roles and ways I can access the portfolio system. So I'm program director for a number of trainees. I might be educational supervisor for some trainees, although as TPD I'm not normally because then there's a conflict of interest there. And I might be an external advisor to an ARCP panel in another reason, for example. And also my own training portfolio is still on there. So I'm going to go in as TPD because that gives me the best view, and I'm going to open this trainee Dushi. So Dushi is one of our excellent SD6 trainees who is just coming towards the end of his training. And when I click on his page, I get a home page which just shows me the activity. So what forms have been filled out recently. And then on the right hand side there's just a summary of the current post which is on there, so you can see 25 days of the training year remaining, and they should have some supervisors there, and that should include an educational supervisor, and it may include also an academic or research supervisor as well. And if you've been allocated as ES to a trainee and you don't appear as a supervisor on the portfolio, you won't be able to open it. So you need to ask the trainee to go in and add you as a supervisor on their portfolio before you'll be able to open it and have a look. Okay, so I'm going to put myself in the position of being an educational supervisor, and it's towards the end of the training year. ARCP is coming up and I need to do an educational supervisor report. So this is the key piece of evidence that the ARCP are going to consider when they decide whether this person can either progress to the next stage of training, or they can CCT and they've finished their training. Now the timing of that is crucial as well. So I don't know how your region is normally, but ideally everything should be on the portfolio at least 2 weeks before ARCP date, and that's in the Gold Guide. So the Gold Guide is the national kind of Bible of training that gives you the rules and regulations around training. And in theory, anything that comes in after 2 weeks before ARCP doesn't have to be considered by the panel, and that's to enable any external advisors, anyone on the panel, to be able to go into the portfolios and review the evidence in advance. And I know personally sometimes I've struggled with things coming in last minute, but it's really good to try and get everything done at least 2 weeks in advance to enable that. Okay, so the first place I would go if I was thinking, okay, I'm going to do an ES report for this person, what have they done so far? Have they done everything they need to? Is on this tab, progression. So there's a number of different tabs across here. You've got profile, which has things like the personal details and the post details. There are some things which aren't really used. So declarations and agreements in most regions, they're not really using that in dermatology training. Certificates and exams, that's a little bit of a legacy, because before we had the ability to have electronic certificates and to be able to scan certificates really easily and upload them, it used to be that you would have to take your paper certificate to your supervisor, who would have to sign to verify to say that they'd actually seen it. So most people put their certificates actually in the personal library, which is essentially where any evidence can be uploaded. The college exams is the SCE, and that actually draws it through automatically. So when the trainee has sat the SCE, I'll open that up. It will tell you the date of the exam and whether they've passed or failed, and that pulls through automatically from the MRCP UK website. Okay, so curriculum. There's usually a number of curricula on here because people will have core medical training or internal medicine training curricula on there, and a lot of our trainees now towards the end of training will have the old curriculum and the new curriculum, although pretty much everyone will have transitioned to the new curriculum at this stage. There might be a few exceptions, but they had to have had only 12 months of training left when it came in, which is 2 years ago now. So unless they've been out of program at less than full time, then they should be on the new curriculum. The assessment tab has all the different types of assessments that we've talked through. Ticket requests, that's where trainees would send you a ticket. So when you get an email saying, can you fill out a form? But you can actually make forms yourself as well. So if you open up a trainee who you are actually the supervisor for, you can click this big green button. So this is particularly good practice if you're doing a mini KEX, for example, and you're asked to come in to clinic opportunistically. So let's say your trainee is seeing a patient with pemphigus vulgaris, and they're switched on. They think, that's a great opportunity to do a mini KEX, so I can add some evidence towards the capability and practice around oral medicine. So you come in and watch them do an oral examination and an oral disease severity score. And then at the end of clinic, ideally, you sit down with them and give them some immediate feedback and go through it contemporaneously in order to get the best experience out of it. And you rather than waiting for a ticket, you can go in, just create the form and select the mini KEX form and create it and go through it. Okay, so reflection is obviously where the trainees can do their reflections on learning and events. The appraisal section has the appraisal tab, which is for things like induction meetings or midpoint reviews. But the ES report, which is the crucial one, is in progression. And the PDPs that they will have done at the beginning, if the rotation should be on there as well. The e-learning, it will draw through from e-learning for health, and they can use that as evidence to say they've met their curriculum. And then the progression tab that we're going to have a look at has the educational supervisor's reports, any ARCP documents, and this important page, which is a summary of progress. And this is a relatively new thing, so this is the first place I'll be going before an educational supervisor meeting to review the trainee. So click on the summary of progress, and the idea is hopefully that the portfolio works out for you what the trainee should have done in terms of numbers of assessments at least, and whether they've done it or not yet. So you can keep an eye on this and make sure that that they are getting through everything in a timely manner. So make sure the correct grade is ticked. So let's say you've got an ST6 and they're coming up to their final ARCP, and then hopefully if it all works and everything's been filled out properly, it should draw it through. So they should have an educational supervisor report, and obviously if you're going to be doing that, that won't be ticked green yet because you won't have done it. And it will bring through their ratings. So we talked about doing ratings, and it will talk through the generic SIPs and the specialty SIPs, and everything should be either meeting expectations or above expectations. As you can see, you've got nice green lights here, which is showing that everything is done. And then with the specialty SIPs, as an ST6, they have to be level 4 in everything because they have to be independent in the whole scope of practice. And you can see that they have been rated as level 4 in all 7 areas. Now that's your job. So if you're an ES and this is the first place you're going, none of those first 3 things will be filled in yet. The surgical procedures similarly have to be rated. Now this is where the technology doesn't quite work perfectly, because if you mark someone as competent to perform the procedure unsupervised, which is correct, that's what they should be doing for CNC, it thinks they should have achieved it earlier and you should have ticked the box that says competence maintained. So it doesn't really matter, but for example, you can see here genital mucosal biopsy, because it's been rated as competence maintained, the portfolio likes that and it ticks it as green. So these are the ones that you have to actually go through and check that they've all been rated at the appropriate level. Non-surgical procedures, again, there's those 5 which have to be achieved at some point during training. And then it will draw through the other important things that are in the decision aid. So the multiple consultant report, these are like the reports from clinical supervisors. So if you're a clinical supervisor, you might be asked to do these, and they're really, really important for informing that educational supervisor opinion, because you're probably not going to be supervising your trainee in the whole scope of practice, if at all. And actually ESs sometimes might not necessarily directly clinically supervise their trainees. And you can go to the summary. So the summary will show all of the ratings, and so with the generic SIPs, green or blue is good. That means meeting or above expectations, and you don't want to see any red. So this person is doing fine there, and there'll be comments from their clinical supervisors if they've put them into their MCRs, which you can read. And if you're thinking about those descriptors about, you know, are they able to you know, to function well within NHS organisational systems? Well, this person has put that the trainee functions well within NHS organisational systems, so you can think, yes, I've ticked that one off. The specialty SIPs, as I said, unfortunately the rating isn't on that 1, 2, 3, 4 level on the MCRs, which I think probably it should be. But you can see that people have graded this trainee as meeting or above expectations from their point of view in those areas. And importantly, you can read the comments. So for those areas around, particularly the specialty areas, which you may not have directly observed, then you can see what the other people's comments have been during that training year. The other thing I like about this page, the summary of progression page, is that it opens things up in as pop-up windows. Whereas if you try and flick through the portfolio and go forward or back, sometimes it doesn't like that. It logs you out packs and whatever. But this is a nice way of just opening things up, and you can close it safely, and you've not lost where you were. MSF, as we said, MSF has to be done every year, and the educational supervisor has to release the summary once you've got an adequate number of responses. So they have to have 12 raters, including 3 consultants as a minimum, and just bear that in mind if trainees are rotating through smaller departments where there might not be that many consultants, that they will need an MSF every year, and if they need to spread that across sort of multiple rotations, to make sure they've got enough raters, then that's okay. So you can look at the summary and just have a look at the kind of people they've had in their doing their ratings, and then this table will show whether they are graded as sort of meeting expectations or above or below, and you can see everything's sort of on the right hand side of the meeting expectations line, which is really good, and no one has any concerns about honesty and integrity, which is also very good. And then of course you can read all the comments here, and sometimes you might draw things out of the comments that aren't necessarily reflected in the ratings. So I think it is worth doing this. So for example, there are comments on this one, which I'll just show you. So there's a comment here: has a very relaxed and unhurried approach to life. However, this does impact on punctuality. So you might think, oh, okay, well, that's worth thinking about. But then you can see other raters have said, Dr. She is always punctual, reliable and punctual, very reliable. So you can kind of triangulate that and think, well, okay, overall, people are saying that he's doing fine with that, and I've got no overall real concern there. And it might be something that you want to discuss with the trainee and say, what's your perspective on it? So that's the MSF. And then the supervised learning events come up, so the other assessments that you'll do case-based discussions, and there's a bar here which will fill up the more assessments that they get done. So you can see they need a minimum of 8 in a year, and this person's got 9 done, so they've got more than the minimum requirement. And at the bottom of each CBD there's a rating again of below, meets or above expectations, and you can just check that they're all kind of meeting or above, and you can go through the CBDs and get a flavour for what level the case discussions have been at, whether they've been spread across a number of different areas of the curriculum. Just make sure they've not all been done on very straightforward cases of BCC or something like that. And you can see, well, this person's done a summary of a case, a 15-year-old boy with severe eczema and a history of Hodgkin's lymphoma. Severe eczema, so this is a suitably complex patient considering systemic therapy in a pediatric patient. So that sounds like a good thing for an ST6 to be doing as a CBD, and you can go through as many of those as you want. You can go through all of them if you wish. The mini kexes, as I say, again, you need 4 of those. This person's got 5, and you can have a look through and again see, are they meeting or above expectations, and zoom in and figure out what are they getting assessed on. So so that's a good way to sort of click in and out without having to go backwards and forwards through the portfolio. There's a couple of assessments in here which you might not be as familiar with, and that's because they're not compulsory. So the OPCAT, which is the Outpatient Care Assessment Tool, is a new thing on the portfolio in the last couple of years. And this is an assessment where you would rate the trainee on their performance over a whole clinic, essentially. So although it's not compulsory, if you've identified, for example, that a trainee is not so good on their time management, so their clinical skills for individual patients might be really, really good, really thorough, but they're going to struggle to get through a whole clinic, then you might say, well, let's do an OPCAT. Let's see how you manage the whole clinic and whether there's anything that we can find as a target for improvement. So that's an optional one. Patient survey. Now, this is an interesting point in the portfolio. So patient surveys seem to be done in lots and lots of different ways. Often you'll get the minimum of 20 responses just uploaded as a PDF, although in theory, that shouldn't happen. In theory, the trainee shouldn't see the individual responses from the patients to essentially sort of protect the confidentiality and keep the comments directly from the trainee. It should be done as a summary of the responses from the educational supervisor. And there is a form actually under the under the assessment section, there's a patient survey summary form which can be filled out. But as I say, often that doesn't seem to get done. So although this says they haven't had a patient survey, what I would then do is probably go into the personal library and just see whether they've uploaded either a summary form or perhaps the responses themselves, just to make sure that they have actually done it. The quality improvement project, again, 1 per year, and you can read, you can click through and read that. Teaching observation, same again. And then the research supervisor's annual report, there's been quite a lot of debate about this at national level because it's a bit out of date. It's not been updated in line with the new curriculum. At some centres use the academic supervisor report, which is perhaps a little bit more flexible. That's what we tend to use in our region. So that's why it isn't pulling through here, because this trainee will have had an academic supervisor's report instead of the dermatology research supervisor's report. So again, you might need to go looking for that and make sure that they've had one done. It pulls through their SCE results, and the ACAT is a bit like an OPCAT, but it's supposed to be for acute care. So it's designed for example, when you're doing a ward round of inpatients, and which you may or may not have the opportunity to do with your trainees, but again, that's an optional thing. So that the summary of progress, I think, is a really good page to start and get an overview of what assessments are there on the portfolio, what are assessors saying, and you can start to form your ratings in your head. And then I would go back and do the ratings. So to do that, you go into the curriculum. So we'll go into the 2021 dermatology curriculum. And this needs to happen before every ARCP. So rather than the old system where it was a mad rush at the final ARCP to tick off everything, I think there was about 70 different competencies listed. This now has to be done each time. And as I said, you've got your generic capabilities. So you would go into that and go into the first one. Does this person have the ability to function successfully within NHS organisational management systems? And if you think, oh, I can't remember what's actually in that, what do they actually need to be able to do? Well, the little I button here, you can click that and it will open up the curriculum descriptors and remind you of the fact that they need to be demonstrating effective clinical leadership, etc. And then you would go on to the button that says rate, and hopefully they might have linked some relevant evidence here as well. And you can rate where you think they are. So are they below meeting or above expectations? And I would encourage you to put some comments in here, because these comments will automatically populate your educational supervisor report. So when you come to do the report, you don't have to duplicate it. It's already been done here. And I'll show you that when we go to the report. So you go through all of the generic SIPs and rate as hopefully meets expectations or above expectations. And then the specialty SIPs, you would go through in turn. And again, you might go, okay, what do they actually need to know in terms of liaison and community dermatology? So we can click on the little I and we can read what the curriculum says about what they're supposed to be doing with that and say, oh, okay, fine, they need to be able to recognise the need for escalation from primary to secondary care. Have they got evidence for that? And then you rate it appropriately, and this time we're rating it, as I said, on the levels 1 to 4 of how much supervision you think the trainee needs in that area still. What we're hoping to do with the portfolio is also to introduce that matrix, which I didn't show you, but as I said, there's a matrix which tells you that at the end of ST4, you should be doing each one of these at a certain level. At the end of ST5, it should be a bit higher, etc. You do have to kind of open that yourself if you want to have a look at it. But we're going to try and integrate it directly into the portfolio, so you can just click on it and bring it up. Okay, so you're going to rate your specialty SIPs as well, and then the surgical procedures. You're probably not going to have observed a lot of these directly yourself, so hopefully they've got the DOPS to demonstrate it. And again, in each one, you have to go through and rate at what level they are doing the procedure based on their evidence that's in the portfolio, and that can vary from unable to perform right through to competent to perform unsupervised, or competence maintained if they'd already been doing it unsupervised in the previous training year. And then finally, the non-surgical procedures, the 5 non-surgical procedures which are compulsory or need to be rated. And similarly, again, it's whether they can do it under supervision or independently. Okay, so you'll do all of that. I think I would do that before meeting the trainee, and it can always be changed later if the trainee, if you meet with them and they point out, actually, no, I have done that, you've just missed it. And then when you meet the trainee, you can then move on to do their ES report. The other things you might want to review before you do the ES report are reflections. So if we go into reflections, now there's no specified minimum number of reflections in the ARCP decision aid. So they basically just have to show that they are regularly reflecting and that the sort of depth of reflection is appropriate. But it's very crucial if there are any things like complaints or untoward incidents, because the trainee will have to declare those before they come to the ARCP. And if they declare it, so long as they have appropriately responded to and reflected on complaints or incidents, it shouldn't be an issue, because we're all going to have complaints or incidents occur at some point during our practice, which is the nature of medical practice. But we need to demonstrate that we respond in the right way to these. As a rough idea, we would usually say a minimum of 1 reflection per month would be expected, and there's lots of opportunities for trainees to do that, to reflect around organised teaching, to reflect around interesting cases they've seen, to reflect around incidents, complaints, management and leadership roles, etc. And the other thing that you'll be asked to comment on in the ES report is the PDPs, the personal development plans. So hopefully way back when you had an induction meeting at the beginning of the rotation, you will have agreed some PDPs with SMART objectives, and commonly trainees will have 2 or 3 things based perhaps around the theme of that rotation if it's got a specialty theme. And you can open that up now. These aren't particularly detailed, but you can review the PDP and whether the trainee has ticked that off as being achieved or not. Okay, so we've had a really good thorough review now of the assessments that have been done. We've got an idea of where we're rating our trainee coming up to their assessment at the ARCP, and we've got an idea of whether they're doing appropriate reflections and what their PDPs were for this rotation, so we can discuss whether they've achieved them at our meeting. Okay, so we'll then go on to do their ES report. So this is in progression under the supervisor's report, and I will bring up the one that's been done for this trainee. So this is the educational supervisor report. Now, whenever you open a lot of bits of the portfolio, you'll notice that here we've got ST6 post selected. So it's just showing us things that have been put on the portfolio during that post. And sometimes you might want to look back a little bit further. So you might want to say, well, actually, I'm not convinced they've got a lot about quality improvement done this year, but perhaps they've done a lot in other years, and you might sort of select all the training years so you can have a look at that particular aspect over the whole of the training programme. Or sometimes the posts don't neatly line up with the sort of 12 months that's being assessed with the ARCP, so you might need to make sure that you've got more than 1 rotation or post selected to capture everything that's been done since the last ARCP. So ES report, we're going to open that up and go through it, and this is what you're going to go through and take a bit of time with your trainee talking through before ARCP. And if you put in the posts that are covered, and if they've been accurately entered, then hopefully it should pre-populate quite a lot of this for you, but it's always worth checking that it's accurate, because, as I say, there are a few quirks with the technology. So the point of doing an ES report is to promote patient safety, to give an opportunity to provide feedback to our trainees, which I think is really crucial, and then to assist the ARCP panel in making their summative judgment. And you have to bear in mind that the ARCP panel often will be people who've never met the trainee. In theory, their educational supervisors shouldn't contribute during the discussion at ARCP. It should purely be based on objective evidence that's in the portfolio. So the first part is generic SIPs, and if you've done your ratings and you've added comments, so these comments in blue here are automatically pulled through from your rating. So you don't have to say anything else, so long as they're not below expectations. So if they're meeting or above expectations and you put a comment in when you're doing the rating, then that's already filled out for you when you do the form. So this is an example of a good ES report where the ES has rated this person above expectations, and they've justified that by saying there's a wide range of evidence presented, highlights including audit and QI work, focusing on organisational issues, so high impact work that they're doing at a sort of leadership and management level. So each one of these ratings has been done, and the comments have pulled through onto the ES report. So that's all of the generic ones. The specialty SIPs, again, are being pulled through from the ratings that you will have done, including the blue comments, which are coming through from there. So let's go to pediatric dermatology, for example. So this supervisor, I know the supervisor doesn't do pediatric dermatology clinics, so they won't have directly observed this trainee doing it, but they've been able to draw on the evidence in the portfolio, and they're satisfied that they've achieved that level 4 capability within pediatric dermatology. And the justification for that is a range of evidence to show that this doctor has experienced a wide range of pediatric presentations, both in outpatients and on call, including rare and severe presentations such as EB and SJS, been able to manage chronic conditions in OPD, including some where management can be challenging, and DOPS showing abilities to form biopsy on a child with an excellent calming manner. So you can see that obviously that's very important to justify the ratings, especially if they're not where they're expected to be. So that would absolutely be crucial. So going through then the generic professional capabilities, that's something different outside of the curriculum. That's basically the GMC. It goes alongside with good medical practice. So you're basically just making an overall judgment for the GMC as to whether you think this trainee is working in line with what the GMC expects of a doctor. So hopefully you're going to tick yes for most of your trainees there. And then it will draw through the number of assessments done in a similar way to the other summary form that we looked at, and you can comment on these, and hopefully you've had a bit of a sampling of them before doing the report. Same for the MSF. The MCRs, again, you can do a bit of a summary of what you've seen in the MCRs, patient survey, and the SCE exam. The PDPs, so have they agreed objective PDPs at the beginning, and have they then met the objective satisfactorily? Comment on the reflections, and then there'll be a section around clinical incidents or complaints. So if you're aware of anything, then you should tick yes. It doesn't necessarily mean that they're going to have a problem, so long as they've engaged appropriately with any investigation. And if you've got any concerns, have they? My mic keeps going on and off. Have they reflected appropriately? Basically on that. And then there's sections about health, honesty and probity. So whether you have any concerns about a trainee's health. Now, do be aware that if you click yes in either of these sections, then it will be mandatory for the ARCP panel to discuss that. I did have one supervisor when I was a trainee who clicked the box yes in health and made a comment that that was a bit of a joke, that they were concerned that I should give up playing rugby because I wasn't very good at rugby and I might get injured. And they probably didn't realise that then that had to be discussed at my ARCP panel. So you've got to treat it like an airport. You know, you don't joke that you've packed a bomb in your suitcase. And then the overall summary of the performance. This is your summative rating of whether you think this person has met the expectations to finish this year of training. And you can add your comments on what's gone really well and any areas that you think might be for further development, and hopefully the trainees will take this into account in their next PDPs. And finally, have you got any concerns? And that's the end of the ES report. And as I say, you can save that in draft if you want to do it before a meeting, but I think it's always something that you'd want to have a meeting with your trainee and go through your ES report, give them feedback based on what you've seen in the portfolio. And where I think I've seen things fall down a little bit is where there have been areas of development or perhaps negative or constructive feedback within the portfolio that people just sort of throw in there and then don't discuss with the trainees. And sometimes trainees aren't perfect and they do need to be made aware of areas where they require further development, but they need feedback in order to do that, and that shouldn't just be, I think, a comment in a form. I think if you've got those kind of comments, then it's always good to discuss that with trainees. And so that's everything that I was going to go through with the portfolio and the ES report. Again, I'm very happy to talk about anything else that's on there, or take any questions.
Well, thank you very much. This was really very detailed and thorough. Are there any questions from the people? No, it seems there aren't any. I mean, I was intrigued that you can use the academic research report instead of a research report for the trainees.
Yeah, I mean, I think it does say research supervisor reports in the ARCP decision aid. But we've had quite a lot of discussion at SAC level about this, because the research supervisor report, number one, is based on the old curriculum, and even for the old curriculum, it's actually arguably the expectations within it are very high. So it says, you know, essentially is working on the expectation that every trainee should have their own single investigator research project, which we know isn't going to be the case. And obviously trainees should be involved in some kind of research or academic activity through their training, but that might be collaborative. It might be getting involved in a Cochrane review group, which is, you know, a very long project. They're not necessarily going to be individually taking that to an ethics committee. So from our point of view, we've taken the local decision to use the academic supervisor report because it's just a little bit less granular, and it seems to lend itself better to the reality of what's expected.
Okay. Are there any questions? No, I think you've answered all the questions. So that concludes then our meeting. Thank you very much for giving us the presentation and for doing it so very well. And the meeting obviously has been recorded and will be uploaded on the Deanery's website, so that people who couldn't listen to it today can do it at a later date. Thank you very much, Matthew, and thanks to everybody who joined.
Thank you.
Yeah, I think that thank yous coming up from various people, so thanks a lot.
my rugby career. To be fair, it was a reasonable comment. I did dislocate my shoulder shortly after that.
Okay. Yeah. Thank you very much. Thanks.